Question number 2. Identify this clinical sign. The options are option A, Levin sign, option B, Beck's sign, option C, Plumberton sign, and option D, none of the above. The right answer is, all of you know that it is Plumberton sign. See, in this picture, you don't see anything in his skin, but you can see the enlargement of the thyroid. You can see that here, and when he puts both his hands up and raises his hands both up above his head, and you will be able to see the flushing of the entire face. What does it mean? This is called Plumberton sign. This is especially for retrosternal goiter. Retrosternal goiter. So, retrosternal goiter, see, enlargement of thyroid is called goiter, and retrosternal extension will cause the thoracic inlet. Understand? Thoracic inlet. So, especially the compression of the superior vena cava. Understand? Superior vena caval compression. So, what happens is the superior vena cava gets compressed and all the tributaries opening into the superior vena cava gets compressed, and you see the flushing in the face. I mean, how do you understand? So, how it can happen? I mean, basically you need to understand how superior vena cava is formed. See, superior vena cava is formed by the two brachiocephalic veins, and these two brachiocephalic veins, how are they formed? See, the brachiocephalic vein on the right is by the union of the subclavian vein with the internal jugular vein, and this is the right brachiocephalic, and joins with the left brachiocephalic, yes, and both right and left brachiocephalic vein joins to form the superior vena cava. So, this is superior vena cava, and try to understand, it opens into the right atrium of the heart, okay. So, it opens into the RA. So, this is the RA. So, this is the interatrial septum, this is the interventricular septum, okay. This is the tricuspid valve, and this is the bicuspid valve. So, this is RA. Understood? Now, if somebody is going to ask you a question, how this internal jugular vein is formed? The internal jugular vein is formed by, on the right and the left. There are two internal jugular veins are there. One is on the right, the other is on the left. Now, let us all try to understand, the right and the left internal jugular vein are nothing but the continuation of the dural venous sinuses, okay. So, they are nothing but the continuation of dural venous sinuses, okay. So, this is about left internal jugular vein. Now, the right and the left internal jugular vein, image or to me. The right and the left internal jugular vein, right internal jugular vein and left internal jugular vein. See, let us try to understand, there are some dural venous sinuses that you need to understand. See, superior sagittal sinus starts superiorly from crista galli anteriorly, and posteriorly it ends in internal occipital protuberance. So, this is fox cerebri. You see that this is a fox cerebri, and this is the tentorium cerebelli. This is tentorium. This is fox. In the superior aspect of fox cerebri, understand, see, the superior aspect of fox cerebri has a superior sagittal sinus. See that, superior sagittal sinus. So, this is the superior sagittal sinus. So, the superior sagittal sinus runs from crista galli anteriorly to the internal occipital protuberance posteriorly. Then it becomes a right transverse sinus, right sigmoid sinus, and becomes a right internal jugular vein. This is right IJV. Now, what happens? The inferior aspect of fox cerebri, this is superior aspect and this is the inferior aspect. This inferior aspect of fox cerebri runs the inferior sagittal sinus. This inferior sagittal sinus, okay, it stops with the tentorium cerebelli and joins great cerebral vein of Callan. This is the great cerebral vein of Callan, and After joining with great cerebral vein of Galen, it becomes a straight sinus. This is a straight sinus. So, the famous entrance exam question is this: how is the straight sinus formed? The straight sinus is formed by inferior sagittal sinus plus great cerebral vein of Galen. This straight sinus becomes left transverse sinus, and this left transverse sinus becomes left sigmoid, and this left sigmoid becomes left internal jugular vein. Very clear? So, I will repeat this once again. Superior sagittal sinus, then we will discuss about the questions. Superior sagittal sinus starts from crista galli anteriorly, goes to the internal occipital posteriorly, and then it becomes the right transverse sinus, and then it becomes the right sigmoid sinus, then it continues as right internal jugular vein. The inferior sagittal sinus runs in the inferior aspect of falx cerebri, ends in the tentorium cerebelli, and then it joins with the great cerebral vein of Galen, and then it becomes a straight sinus. Straight sinus again goes to the internal occipital protuberance, and then it becomes the left transverse sinus. So, this is the left transverse sinus, and this left transverse sinus, this is left transverse sinus, becomes left sigmoid sinus, and this left sigmoid sinus continues as left internal jugular vein. Very clear? Now, you know that how right internal jugular vein and the left internal jugular veins are formed. Okay. So, the subclavian vein, how is the subclavian vein formed? See, the subclavian vein is formed by the continuation of axillary vein. So, continuation of axillary vein, and how is the axillary vein formed? Axillary vein is formed by the continuation of basilic vein along with the vena commitans of veins. I will repeat again, the subclavian vein is formed by the continuation of axillary vein, and the axillary vein is formed by the continuation of basilic vein, and the basilic vein along with the vena commitans of the arteries forms the axillary vein. So, this is all about the anatomy of the internal jugular veins. So, there was a question very interesting which was asked in 2 years back in the exam, NEET exam. It was, if this left brachiocephalic vein is absent, if the left brachiocephalic vein is absent, what will you think of? So, if the left brachiocephalic vein is absent, you should think of LSVC, left sided superior vena cava. And if there is an LSVC, you should also think of coronary sinus type of AST. I am coming again. If left brachiocephalic vein is absent, then you will have to look for left sided superior vena cava and associated with coronary sinus type of AST. The most common type of AST? The most common type of AST is ostium secundum type of AST. That is the most common type of AST. So, this is about superior vena cava. Now, the superior vena cava is located in the right side. Understand, this is in the right side. So, there is more dead space on the right side because veins are collapsible. So, on the right side of the mediastinum. Which mediastinum? Right side of the mediastinum, which mediastinum? Superior mediastinum. So, superior mediastinum has, the right side has superior vena cava and more of dead space. So, if at all any tumor that has to occupy the superior mediastinum, it will grow more on the right side, understand, because there is more space. So, it will grow more on the right side. So, whenever the superior vena cava is obstructed, and it is called superior vena cava syndrome, superior vena cava syndrome. And the superior vena cava syndrome could be caused by lung cancer. The most common lung cancer that is causing superior vena cava syndrome is squamous cell, understand this, and that is called Pancourt's tumor. Lung cancer, squamous cell followed by small cell, otherwise called superior sulcus tumor, understood. And enlarged goiter, enlarged thyroid, retrosternal extension again can cause compression of the superior vena cava, and those veins and tributaries draining ultimately into the superior vena cava gets compressed so that you see the flushing in the face and the upper aspect of the chest. So this is about superior vena cava syndrome, by far with the obstruction at the level of thoracic inlet by the retrosternal goiter. Now there is one more question which is asked. What is the most common cause of superior vena cava syndrome? Which tumor most commonly causes superior vena cava syndrome? The most common cause of superior vena cava syndrome, the answer is lymphoma. Remember this, lymphoma. See, most of the time the treatment for lymphoma becomes chemotherapy and radiotherapy. And how do you treat the superior vena cava syndrome in lymphoma? The answer is, whether you give chemotherapy and radiotherapy, along with that you will put a stent in the SVC. So you put a stenting. So SVC, superior vena cava stenting, becomes the treatment of choice. Understand? So this is all about the superior vena cava obstructed by the thyroid or other tumors. What are the most common tumors? Now I will ask you one more question. What you should not do in case of retrosternal goiter? The question becomes very simple. Will you give anti-thyroid drugs? Can you use an anti-thyroid drug in case of retrosternal goiter? This question was a very famous question. Try to understand, whenever you give an anti-thyroid drug, when you supplement with anti-thyroid drug, then TSH levels definitely be reduced. So whenever you give an anti-thyroid drug, okay, whenever you reduce the level of T3 and T4, automatically TSH level will go up. So automatically TSH level will go up, and when TSH level goes up, it will increase the growth of thyroid. So when the thyroid will grow more and the retrosternal compression and the symptoms will be more. So I will repeat this once again. Will you give an anti-thyroid drug in patient with retrosternal goiter or not? Answer is you are not supposed to give. When you give anti-thyroid drug, it will reduce T3 and T4 levels. As a consequence, TSH level will go up, and so it will cause further enlargement of goiter and symptoms will become much worse. So don't do that. And you treat with, if any toxic symptoms are there, you better treat with beta blockers. You give Lugol's iodine, sodium iodide or potassium iodide. So you can treat better in that way. Okay. So this is about Plum-Burton sign. So Plum-Burton sign is for the retrosternal extension. Okay.